I think we did discuss appendix. I think we're going to move on to one of the acute condition, and one of those is intestinal obstruction or bowel obstruction. Now, when we talk about bowel obstruction, bowel obstruction, there is small bowel obstruction, there is also large bowel obstruction. So, we're going to start first of all with small bowel obstruction, right? Now, what are the causes of small bowel obstruction? Again, we said we have, when we talk about differential diagnosis, we speak about the causes, we have a system that we use to deal with those issues. And the system is it is called a diagnostic sieve. So what are the causes of obstruction? There's congenital, okay, trauma, inflammatory, right? Inflammatory like Crohn's disease and so forth. And then from there we have neoplastic causes. So inflammatory things like also adhesions, and then neoplastic causes like malignant tumors, benign tumors, all right? And then we can also include under inflammatory things like twists, like volvulus, intussusception, and so forth. So there's always a system that we use to deal with these things so that we don't make it difficult for ourselves. Okay? So the causes of small bowel obstruction. So we're going to start first off. So usually what we start with when you say, okay, bowel obstruction, small bowel obstruction, that is. What are the causes? First, we start with the commonest one. We always start with the commonest one. And then once we have now exhausted the commonest one, then we say, okay, now to make it easy for me to remember, I'm going to use the diagnostic sieve. So you can see it's a very powerful tool, this diagnostic sieve, because it helps us to navigate some of the challenges, when we deal with problems. Sometimes in the exam, we're a little bit under the couch, and under the crouch, and under the crotch, and people are asking you questions, you're a little bit nervous. So to get yourself out of that little tight spot, then you use the diagnostic sieve. So let's start first of all with the commonest condition. It depends. The commonest cause of, remember, we said there is small bowel obstruction, large bowel. We must distinguish between the two. The two are distinct. They are distinctly different. And the management is also different. So you have to get it in your mind, I think that distinction, appreciate the distinction, and then it will make it easy for you to manage the patient with small bowel obstruction. Okay, what are the common causes? Small bowel. By far, the commonest cause of small bowel obstruction is adhesions. Patients that have had surgery before, for whatever reason. For example, they've had gunshot abdomen, they were operated upon. Now, they have signs and symptoms of intestinal obstruction. So, by far, the commonest cause is adhesion. But clearly, if somebody has not had surgery before, you can't say commonest cause is adhesions, because yes, adhesions can form in somebody who has never had surgery before. We know it's possible, but it's rare. By far, the commonest scenario is a patient has had previous abdominal operations before, and now they have bowel obstruction. So, adhesions are by far the commonest cause of small bowel obstruction. Very close to adhesions are things like hernias. Hernia, and then we have different types of hernia according to their anatomical location. For example, we have hernias which occur in the ventral part of the abdomen. Remember the ventral part, the anterior part, which is called the ventral, and the posterior part is called the dorsal. So we call ventral hernia, for example, abdominal wall hernia, they're ventral, they're anterior. We can further divide them into those that occur in the groin hernia, like a femoral hernia, inguinal hernia. Then we further divide them those that are going the umbilical hernia. Okay, so this is how you tell. All right, so hernias, and then we have now the other causes which are less common, which now we would utilize the diagnostic sieve to assist us in picking up or deciding the other causes. Can you get congenital bowel obstruction? Yes, you can. For example, duodenal atresia in a little child, duodenal atresia because of, remember, during embryology, the gut rotates, the bowel. So you may have duodenal atresia. You may have intestinal atresia. For example, duodenal atresia, the child's vomits, they got bowel obstruction. But this bowel obstruction is really mainly the stomach that is mainly the problem. So it's the duodenum. So usually when you do x-rays, you do a dilated stomach, dilated duodenum. You had a double bubble, okay? Or double fluid levels, or double bubble, or the double bubble sign. Why is double bubble? Double, two. Because it's the duodenum. So you have distension of the stomach, the first bubble, and then the duodenum, second bubble. That's why it's called a double bubble. But obviously, if it's jejunal atresia, it's not going to be double bubble. It's going to be multiple bubbles because the bubble of the stomach, bubble of the duodenum, bubble of the jejunum, many other bubbles. So that's atresia, congenital. Clearly, a 67-year-old man or a 90-year-old, you can't say congenital because if it's other. So remember, this diagnostic seed is just a tool. You have to know how to use it, all right? So it's a congenital. Oh, no. Congenital doesn't work here. No. The patient is 75 years old. The patient is 50 years old. If the patient was 3 years old, 3 months old, that's a different discussion altogether than congenital cause. So we say, okay, the diagnosis starts with the congenital, but this congenital is not relevant here because the patient is adult. Okay, fine. Good. I understand that. So, okay, what is it? The other one is inflammatory. Inflammatory is a very encompassing term. It's very broad, it includes a whole host of things, inflammatory things like inflammatory bowel disease, which inflammatory bowel disease results in obstruction and Crohn's disease. Crohn's disease, remember, can affect from the mouth to the anus, is inflammatory bowel disease. Ulcerative colitis is mainly the colon. So remember, we're talking small bowel obstruction. So we should inflammatory conditions like Crohn's disease. So it can cause bowel obstruction. Infective causes. Can there be infective causes that cause bowel obstruction? Absolutely. Yes, of course, it can. How? You can get, for example, infection with TB of the abdomen. Remember, TB can affect the bone, can affect the muscle, can affect the stomach, can affect the brain, can affect the eye, can affect any part of the body. So you can get infection of the bowel, small bowel, stricture from TB, infective causes. All right? And then, of course, still under infective causes, things like twists. It's not really infective, really, but you could get, for example, inflammatory twists like volvulus of the small bowel. All right? And then, of course, inside the small bowel, people can eat all sorts of things. People eat bezoars, they eat all sorts of things, and that can obstruct. Worm infestations, ascaris, in the loop of the bowel can cause obstruction. And then we go to the other theme. Do you remember the theme? We've talked about the congenital. We spoke about inflammatory, infective. What is the other theme? Who remembers the other theme? What is the other theme? The other theme of the diagnostic scene. What is the other theme of the diagnostic scene? Who remembers it? All right, Mpe, help us there, Mpe.
Good evening, Prof.
Yes, go ahead, yes.
The other one is neoplasms.
Yes, correct. The other theme is neoplastic causes. And remember, you can break it down. The neoplastic causes, you can break it down into malignant neoplasm, and then malignant can further break it down into primary neoplasm, secondary. Because you can get secondary tumors, primary tumors of the small bowel, for example, adenocarcinoma of the small bowel, neuroendocrine tumors of the small bowel. You know, those are primary tumors. You can get or leiomyosarcomas of the small bowel. But secondary, you have, for example, melanoma. Melanoma can metastasize to the small bowel and cause obstruction. Amazing, right? And other tumors as well. Okay, so when you say neoplasm, you say malignant, primary tumors, secondary tumor, and then we have benign tumors. For example, you can get a GIST. What is a GIST? A GIST is a gastrointestinal stromal tumor. Oh, that's a mouthful. Repeat, what is that? GIST. What is that? Gastrointestinal stromal. It's a fascinating tumor. It is a tumor that occurs, it's not a tumor that occurs, for example, from the mucosa, because remember, the tumors that occur from the mucosa, what do we call them? We call them carcinoma. Carcinoma, what does carcinoma mean? Carcinoma means a tumor that arises from the mucosa. Any mucosa lining, for example, you can get a carcinoma of the pancreas. What does it mean? It means it arises from the mucosa of the pancreatic duct. You can get a carcinoma of the breast. It means it arises from the mucosa of the duct, the breast ducts. You can get carcinoma of the esophagus. It means it arises from the mucosa of the esophagus. Carcinoma of the stomach. It arises from the mucosa of the stomach. Carcinoma of the colon. It arises from. So carcinoma by definition is a tumor that arises from the mucosa. Anywhere we have a mucosa, it will be a carcinoma. But now this one, GIST, is not a carcinoma. It doesn't arise from the mucosa. Where does it arise from? It arises from mesenchymal cells. These are not mucosal cells. They're within the wall of the organ. You find these mesenchymal, they are very special mesenchymal cells, and they're called interstitial cells of Kajal. So Dr. Kajal was the first to describe it. It is called interstitial cells of Kajal. They are, some people call it pacemaker cells, almost like the ones you find, Purkinje fibers you find in the heart. You know, they are fascinating, right? They arise from the stomach. 85% of them are located in the stomach, but you also find them in the duodenum, in the jejunum, in the colon, but they are very rare there. They are common in the stomach. So they are mesenchymal cells. So do we call them carcinoma? Of course not. They are not carcinoma. What do we call carcinoma? Carcinoma is cells or tumors that arise from the mucosa. So these ones don't qualify to the definition of carcinoma, which is a tumor that arises from the mucosa. So this one is not, it is a mesenchymal cells. These cells are not in the mucosa, they are found in the wall of the stomach, interspersed. Some people call them the pacemaker cells. Some people, so they are called the interstitial cells of Kajal. So that also, can you get them in the small bowel? Of course you can. Do they arise from the mucosa? No, they don't. These just are not carcinomas. They arise from the mesenchymal cells. These are cells in the wall, right? So they can cause obstruction, but they're rare, of course. And then you can also get obstruction from outside. Because there is a lumen, within the lumen, in the wall, or outside. Any pressure from the outside, for example, a big retroperitoneal tumor can obstruct the small bowel. Now, do you realize how easy it is to work it out? To work it out, oh my goodness, it's easy. This is painfully simple. Absolutely easy. Right? So it's easy. You don't have to stress. And then you scratch your head, you want to memorize and remember. No, this is easy stuff. Okay? Right. Those are the causes of, and then how do we make a diagnosis of small bowel obstruction? Can somebody tell me, when we say how do we make a diagnosis, what do we mean? Can somebody tell me what do we mean by that? How do we make a diagnosis of small bowel obstruction? Exactly what are we asking you? What can you break down that question for me? Okay, let's ask Mbombi. Okay, Mbombi, help us there, Mbombi. Just break down that question for me.
Evening, Prof. Am I
How do
audible?
you make it? Yes, go ahead. Go ahead. Yes.
So when you make a diagnosis, you want to know what are you going to find on history, on examination, and on investigations that's going to support your diagnosis.
Correct. Yes, that is what we meant. So it is a very loaded question. It's a loaded question because it's got little other parameters that we need to look at. As you correctly points out, you want to know from the history what's just bowel obstruction from the history, and then on examination as well as on investigations. All right. So the history they complain of vomiting. Usually they vomit bile stain vomiters. Is it important to know whether it's bile stain or not? Yes, it is important because patients with gastric ulcer obstruction, they are not strictly speaking called bowel obstruction patients. They have a specific pathology which is called gastric outlet. But those ones, they vomit food that does not contain bile because the obstruction is before the ampulla of fat and the duodenum where the bile comes. So before, so they're going to vomit something that doesn't contain bile. But these ones with intestinal obstruction, they vomit bile stain vomitants. Bile. They vomit bile. Even if it's children, they vomit bile. They vomit bile. All right? And then they have colicky abdominal pain. What is colicky? What does it mean? Colicky. Colicky abdominal. What does that mean? Colicky abdominal pain means is a pain that waxes and wanes. All right, it comes and goes. So it comes, increases with intensity, and then it dissipates. Comes, gets worse, dissipates. Comes, gets worse, dissipates. That's what a colicky abdominal pain. Now we're going to explain when we talk about pathophysiology why today patients come have colic abdominal pain. The pain comes and goes, comes and goes, comes and goes, comes and goes. So we're going to explain to you and it is fascinating to understand why is it colic abdominal pain. And when we understand, how this occurs, then it's easy to remember this. This colicky abdominal pain. We'll come back to that. They also complain abdominal distension, constipation. And they complain constipation or obstipation. What does obstipation means? There is not even gas that's coming out. They're constipated. Then, doctor, I haven't passed stools at all. There's no gas that comes out. They're obstipated. They've got abdominal pain. And then depending on whether or not this bowel obstruction has now gone to complicate, they may appear, they may be peritonitic, they have peritonitis, signs of acute peritonitis. What is acute peritonitis? It means tenderness everywhere. The abdomen, you touch here on the left is tender, on the right is tender, on the upper abdomen is tender, lower abdomen is tender, all over the abdomen is tender. That's peritonitis. So you touch the abdomen, it's tender everywhere. You've got peritonitis, and they've got rebound tenderness. So they're tender when you touch, but when you press and let go, they also have tender. So they've got generalized tenderness plus rebound. Rebound means specifically you must press hard and let go. It rebounds, and the patient gets pain. So again, it's another sign of peritonitis. So when you do a rectal examination in this patient, you do the rectum is empty, right? So that is, and when you listen with the stethoscope, what are you going to hear? You hear increased bowel sounds, a tinkly sound. It's almost like the patient is hungry, hasn't eaten in a long time. So they have this increased bowel sound. And there is interesting, terminology that they use in surgery. It's a tinkling bowel sound. There is also another when the bowel is full of fluid like that. So we have what is called boborygmy. Boborygmy. What is boborygmy? Boborygmy is where now it's not really contraction per se. It is because the bowel is full of fluid. As you move position, fluid gushes from one segment to the next and gives this sound, which we call boborygmy. It's also a sound that you find in bowel obstruction, but the one that is really because of peristalsis, is increased bowel sounds. So I'm going to now talk about the pathophysiology. Remember, we spoke about the pathophysiology of appendicitis. How does it occur? Is obstruction, secretion? You remember? Who remembers the pathophysiology of acute appendicitis? We spoke about it yesterday. Who remembers it? Do you remember that? What we spoke about yesterday? Do you remember? Right. Okay. All right. That's fine. I think people can still remember. That's fine. Okay. So this is now what you do. So the pathophysiology, this is what happens. When you get obstruction, whether it's from adhesions or from a tumor or from a hernia, what happens? This is what happens. It's almost exactly the same like appendix. You see, this is exactly what I was saying. You learn one principle, you apply it across the board. What's happened? So you got obstruction. So what happens? Now the body senses there is obstruction because you see, this is how the good Lord has made a human being. A human being must, that's how a human being can survive to 120 years old, like Methuselah, 90 years old, because there's this mechanism, inbuilt mechanism within the system of the human being to safeguard the human being's life. All right, so this little thing, so now the body senses there's obstruction. So it says, oh my goodness, there is trouble here, there is obstruction. So the body tries to overcome this obstruction. So what does it do? The body increases, it's a reflex, it's a defense mechanism. So the body increases peristaltic activity because remember there's peristalsis, so it increases. So, and this peristalsis is throughout the GI tract, not only obstruction. So you get peristalsis above the obstruction, below the obstruction. All right. So, and when you get this obstruction, what is going to happen? So, bowel contracts with greater intensity. And what happens when you do that? So you're going to have increased bowel contraction has increased. So increased bowel sounds. But not only that, it is with increased intensity. They get colicky pain, contracts, and then you get this colicky pain. That's why they get colicky pain. And then the peristaltic wave dies down. Another one comes back again. So the first thing that occurs is, or one of the first things that occurs is increased peristaltic activity. And this occurs, it's important to understand that. It occurs above and below the obstruction. So even below the obstruction, that's why sometimes patient with obstruction, they pass stools. But the patient is passing stools. Why you say it's obstruction because passing stools? Remember, at any given time, if you look at the GI tract, there were stools everywhere. Stools in the splenic flexure of the colon, stools in the hepatic flexure of the colon, stools in the transverse colon, ascending colon, descending colon, the rectum, sigmoid. There's stools there, columns. It's just that it hasn't reached the area where you need to feel to want to go to the toilet. So if there is stools in the sigma, there's obstruction. So the patient will clear that. And that is why when you come after a while, you do a rectal examination, the rectum is empty. All of that has been emptied by this peristaltic activity, which is a defense mechanism, right? To try and overcome the obstruction. Is that all that happens? No. Not at all. There's still many things that are going to happen. We're going to list these things that happens in bowel obstruction. And one of those is increase, there is a peristaltic activity, but there is also increased fluid secretion. Remember in the appendix as well? Remember we said that? Okay, appendix is not much peristalsis there, but the secretion of fluid. Why does the body do that? Is one of the defense mechanisms to try and flush out this obstruction. So there's increased body secretion, fluid secretion, and sometimes we call this third space loss. Now do you understand why patients with bowel obstruction, they need fluid? They need plenty of fluid because they lose a lot of fluid. There's a lot of fluid that comes in the lumen of the bowel. And why does it happen? It's trying to overcome obstruction. So there's fluid secretion there. Is that all? No. There's still more. So what's going to happen now? Now remember, now there's fluid, and there is distension. Okay? So what happens now? Because Are there bacteria in the bowel? Yes, at any given time. Remember, there are good bacteria, bad bacteria. In the small bowel, there's bacteria there. There are also that are important in the body homeostasis. But also there's bacteria that occurs, that are harmful. All right? So remember in the colon, the bacteria are more, millions compared to small bowel. The small bowel also has got bacteria. So now, where this is, what's going to happen? There is bacterial overgrowth. Because now there is just stasis fluid inside bacterial overgrowth. Is that all? No, not all. There's still more. There's still more. What is more now? Okay, now what happens? You get distension with fluid. So what happens? There is pressure that builds up within that closed loop or that obstructed segment of bowel. Because there's increased fluid secretions. So pressure builds up. Just like in appendix, remember there's obstructed fluid builds. And then when this fluid builds up, it increases the pressure. What happens? The pressure now presses onto the mucosa and the wall of the bowel. Just like appendix, what happens? Now, in the wall of the bowel, what do we find there? We find a number of things. We find the little veins, the little arteries, capillaries. We find lymphatics there. They're there in the wall. So when you press, what's going to happen? You're going to press the veins. So when you press the veins, what happens? Venous return decreases. So there's edema. You press the lymphatics, also lymphatic, return also decreases. Edema as well. You press the arterioles, the ischemia of the bowel. And then when the ischemia of the bowel is going to perforate, just like appendix. Do you see how easy this is? You just learn one. You apply it across the board. So when we ask you, then there's no need to panic and now start scratching your head. No, just explain it because it is unbelievably simple. It is incredibly simple. Okay? Who agrees that it's simple? Raise your hand. Who agrees that this thing, this is simple? Right. Thank you very much. Okay. I'm glad that you also agree that it's easy because that's the first step. Once you agree that it's easy, then you'll master it. But once you tell yourself it's difficult, you're gonna struggle, you're gonna battle. Right? This is easy, and it's not an exaggeration. It is easy. It is simple. Okay. All right. Now we have ischemia. Now remember, there's bacterial overgrowth. Now there's bowel. There's ischemia. There's going to be bacterial translocation, infection, edema of the bowel, fluid loss. Right. So now I want somebody to explain to me, right, why do these patients need fluid? Patients with bowel obstruction. One of the things that we do when we have to give them fluid. Can somebody explain to me why do we give them fluids? Apropos what I've just said in my explanation of pathophysiology. Somebody tell me, why do they need fluid? Anybody? Anyone? Okay, let's ask Chile. Chile, help us there, Chile.
Good evening, Prof. So these people with bowel obstruction, they lose fluid in terms of increased fluid secretion into in terms of third space laws, trying to overcome the obstruction.
Yes, correct. You're correct. It's in the lumen, the third space laws. You see, it makes it explains why they lose fluid. Yes. Secretions, they're trying to overcome the obstruction. That's why we have to give them fluid. Now, can somebody explain to me why do we have to give them antibiotics? Antibiotics. Anybody? Why do we have to give them antibiotics? Okay, Mpe, help us there, Mpe. Why do we have to give them antibiotics? Mpe, help us there.
Evening, Prof. So we give them antibiotics because of the bacterial overgrowth from the stasis.
Mm-hmm. Correct, yes. But this bacteria, remember, you are absolutely correct. It's bacterial overgrowth from stasis. But that bacteria doesn't stay in the bowel because now remember there's also ischemia. So the bowel integrity is bacterial overgrowth in the lumen, and it also goes outside because now the bowel integrity is compromised. So we call this process where bacteria now, they overgrowth, as you said, you're correct, but they also go outside the lumen. And that process is called bacterial translocation. They translocate from their natural position in the lumen outside, and then into the bloodstream everywhere. So that is why when patients with bowel obstruction, you must give them antibiotics because of bacterial overgrowth and translocation. Now, somebody tell me why patients with bowel obstruction, why did they perforate eventually? The bowel perforates. Can somebody explain to me why? Why do they perforate? Because if you leave them long enough, they want to perforate. Why? Anybody? Why do they perforate? Okay, help us, Botholo.
So,
Help us there.
evening, Prof. So we mentioned that
Yeah.
there is increased pressure in that segment whereby there is bowel obstruction. And then we mentioned that the wall of the bowel contains arteries, veins, and lymphatics. So if the arteries are compressed, there'll be ischemia, and then that will result to perforation.
Correct. Absolutely correct. Yeah, that's perfect. You've said it very well, right? Anybody? Are you all following, guys? Are you all on in sync with us? Everybody's. Are you all in sync? Yes. Correct. Now you realize that when the patient has got a bowel obstruction, if you leave them long enough, they're going to perforate and die. So you have to deal with this problem. Okay, now the other thing that they do, and remember we said they vomit bile, but sometimes if the obstruction has been going on for a long time, they drain or they vomit not bile, they vomit fecaloid material. It's not feces, but it's called fecaloid. What is fecaloid? Fecaloid means it looks like feces, but it's not feces. Now I'm going to explain why they vomit fecaloid material. Now, in the lumen of the bowel, you get bile. There's little bacteria there. When there's stasis, bacterial overgrowth. Now, this bacteria, they overgrow. Then they work on the bile, or they alter the bile from, bile, remember, has got bilirubin. It's altered to stechobilinogen. So the bacteria changes it to stechobilinogen. And stechobilinogen color has got a characteristic brown color. And that is why the stools, when you go to the toilet, the stools are not green, the stools are brown because of stechobilinogen. So the reason why when they vomit this brown color stuff is because bilirubin has now been acted upon by this bacterial overgrowth and changed from the green bilirubin that we know to the brown stechobilinogen. So when the patient vomits, they no longer vomit bilirubin, which is green, or bile, which is green. They vomit brown. Then we say they are draining, they are vomiting fecaloid material. And what is the clinical significance of that, of fecaloid material? The clinical significance is that it means there has been a prolonged period of obstruction. So there's sufficient time to enable this bacteria to change, because it's a process to change. It's like milk. From milk, you're making cheese, and then you're making yogurt. It's going to be a fermentation process to making cheese. The same applies here. Bilirubin now over time has now been, so it means this obstruction is not yesterday. It's not 2 hours ago. It has been going on for a long time. For the patient to drain fecalate or fecaloid material means the obstruction has been ongoing for a long time. And what does that mean? It's got serious implication, because it says to you, oh my goodness, all these things we're talking about, fluid secretion, increased peristalsis, compression of the arteries, is probably happening now. So because it means it has been ongoing for a long time, because all this time there was increased secretion of fluid in the lumen, there was bacterial overgrowth, there was compression of the veins, compression of the lymphatics, compression of the arterioles, there probably ischemia. Therefore, in other words, it's a surrogate marker of possible ischemia because it says to you, hey, this has been ongoing for a long time, so watch out, there's problem here. So when you see a patient like that with a fecal material, it is a red flag. Red flag, trouble, 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 and then watch out the trouble and sort it out as soon as possible. All right, so now, do you guys understand now the importance of the fecal material? First of all, what does it mean? And what is its clinical significance? It means long-standing. It means long-standing, and not only long-standing, but the possibility of ischemic bowel perforation is imminent if it has not occurred already. Okay, so that is now the pathophysiology of small bowel obstruction, right? Is that are you guys following? Who understands the pathophysiology? You can rattle it, even if you ask me 2 o'clock in the morning, I can rattle it just like that. You ask me, if I wake up from sleep, you ask me this, I can rattle it just. All right, good. I think everybody understands. Okay, we're gonna move on. Okay, we're gonna move on. Thank you very much. I think everybody understands. I can see everybody understand. That's good. Okay, we're gonna move now. So when the patient comes, we examine them now. Remember, the thing that's going to kill the patient with bowel obstruction is where there's ischemia, perforation, there is translocation. That's trouble. Where once you reach that stage, there's a possibility that the patient can actually die. The patient can die. So we need to, and there are things now, therefore, that help us, the clinical things that help us assess the possibility that the patient is having ischemia. It's almost like when it's going to rain. When it's going to rain, you see there are dark clouds. There's this moist wind that comes. So, there's a storm coming. The dead patient. Patient gonna die. It means this is danger, danger, danger. Recognize danger from miles away. So we really want to know. So, and we call this bowel, which is now ischemic compression. There's a fancy term they call complicated bowel obstruction. What is that? What is complicated? Basically, what they're saying is that there's ischemia and watch out. It means there's ischemia, impending perforation, possible death. What does it mean? It means you must move with speed to deal with this patient. Otherwise, you're going to end up with a mortality. And that is why we always ask you, because when you are a GP working in casualty, you must be able to recognize, hey, there's danger here. Hey, this guy is draining fecal material. He's got possible complicated bowel obstruction. I need to call the surgeon now, not tomorrow, not after 6 hours. He must come now. Otherwise, this guy, we're going to lose him. Okay? So, and what are the telltales? One of the things that we look at is not always indicative, because sometimes you see there's rain and then the wind blows the clouds away, and the rain doesn't come. So similarly here, so one of the things we look at is if the inflammatory markers, patient looks sick, inflammatory, he's got obstruction, we've made a diagnosis, and then inflammatory markers are raised. Things like, for example, he's got a high temperature, he's got a high pulse rate. So the temperature is high, and then CRP is high, procalcitonin, these are inflammatory markers. They're all raised. Okay, he feels feverish. He's sweating. He looks sick, this man. All right, and then when we examine his abdomen, the abdominal finding, again, we're looking for ischemic bowel or strangulated bowel from obstruction, but sometimes we call it complicated obstruction. So we're looking for things like this. We're looking for tenderness when we examine the abdomen. The abdomen, okay? And then the other thing that I forgot to mention was if the nasogastric tube is draining fecalent material, we mentioned what is fecalent material. What does it mean, fecaloid material? No, it's not feces, fecaloid material. And then if there's tenderness in the abdomen, and then there are certain telltale signs, for example, on investigations. For example, the white cell count is raised, the CRP is raised, procalcitonin is raised, all right? There's something going on here. But it's not always like that. So if you put everything together, and then arterial blood gas got metabolic acidosis, all of those things, remember, on their own, they may mean just dehydration. But if you put them together, say, this is a red flag. There's probably dead bowel here. So we need to look for it and make sure that we deal with the patient. The patient doesn't end up with a problem. Okay, so that is bowel obstruction, complicated bowel obstruction. So now, one of the things that we talked about, investigations. Remember, I said, how do you make a diagnosis? History, examination, and then investigation. Can somebody tell us now, what are the principles when you say investigations? What do we do, and what are what is the framework that we work on when you say investigation of any conditions? What framework do we use for investigations? Or what pathway do we use for investigations? Anybody? Okay, let's ask Sikukuni. Sikukuni, help us there. Sikukuni, help us.
Prof, we start with the cheapest and the easily accessible and non-invasive ones.
Yes, you're correct. The cheapest, the most widely available, the non-invasive, tests that we do. And then which ones are those? Sikukuni, help us there. You are correct. Which ones? Which ones are those?
You can start with your side room tests, your X-ray and ultrasound.
Yes, you start with the simplest one, ultrasound. Even in the most remote part of South Africa, you'll find an ultrasound machine. X-ray, you'll find it. Even in clinic, they do have X-ray machine. So X-ray is widely available. So which X-ray do you do? Anybody? Which X-ray do we have for abdomen? Which X-ray do we do? Which X-ray do we ask for? Anybody? Which X-ray do we ask for? Okay, Mbekwa, let's ask Mbekwa. Mbekwa, help us there. Which X-ray do you ask Mbekwa?
Good evening, Prof. You're going to ask for the chest X-ray, abdominal X-ray, supine, and erect.
Yes, correct. So there's always 3 X-rays. Remember we spoke about that yesterday? Abdomen erect, abdomen supine, chest erect. Why do we want them 3? Because on erect chest, we want to see if there's free-ended diaphragm, is it complicated obstruction. Erect abdomen, we want to see fluid levels, and then distended loops of bowel on a supine X-ray. So those are the things that we do. So we start with the first, and then the next one, we ratchet it up. And then what is the next investigation we do? We spoke about it. Remember, we just have to learn it once. You apply it everywhere. We learn it once, and then you apply it everywhere. The other X-rays, the other investigations, apart from the simplest one, what else do we do, investigation-wise? Anyone? Remember we spoke about, okay, Mpe, help us there, Mpe.
Evening, Prof. Once we are done with the X-rays and the ultrasound, we move to blood tests. So the blood test that we'll do will be a full blood count to check for the hemoglobin, the white cell count, and the platelets before we can even take the patient to theater will do a UNE to check for the renal status of the patient.
Correct. We have to, those the blood tests, the full blood count, the urea electrolytes, urea creatinine electrolytes, liver function test, the inflammatory markers, we all do that. Why do we do a UNE in these patients? Can somebody tell me why you want to do a, okay, let's ask Munisi, help us there, Munisi. Why do we do a UNE?
So, Prof, we want to assess the renal function because with a contrasted CT scan, we will be injecting the contrast, so it is nephrotoxic. We want to make sure that the kidneys are healthy to be able to deal and excrete the contrast.
Yes, correct. You're correct. Because remember, the next investigation, remember we started with the simplest, so we're going to rush it up, and now we're going to do image, we do cross-sectional imaging. But we cannot do contrasted CT scan without knowing the renal function. Because remember, as you said, the contrast that we use during the CT scan is nephrotoxic. So we want to know, for example, if the urea is high, what do we do to ameliorate kidney injury? So we would give this patient fluids before we give them contrast. Okay, so if you didn't know the renal function, you won't be able to give fluids. So we wouldn't give fluids. So the patient, we need to know the renal function of this patient, then we give fluids. Correct. Absolutely correct. All right. Now, so we do a CT scan. Now, we've moved a long way. In the past, we used to do only chest X-ray, but now the CT scan has really become a very critical investigation tool in the management of patient bowel obstruction. So we do a cross-sectional imaging CT scan. Why is CT scan called a cross-sectional imaging? Why is the X-ray not a cross-sectional imaging? Why do we say CT scan? We do cross-sectional imaging. Why? Anybody? Okay, Munisi, help us there. Why do you call it a cross-sectional imaging? Yes, go ahead, Munisi. Go ahead, Munisi.
Yes, Prof. I remember when you told us yesterday, you said it's because you can be able to do in three planes. You can do a coronal, you can do a sagittal, and you can also do a frontal plane. So we can be able to.
Yes, because cross-section means it gives you different cross-sections of the body. Coronal cross-section, sagittal cross-section, axial view. So it gives us different. And then MRI, is it also cross-section? Yes, MRI is also cross-section because it gives you different views. Okay, now the CT scan helps us identify, high-grade obstruction. It helps us identify, we're going to talk about what's high-grade obstruction, identify ischemic bowel as well, CT scan. So CT scan has become very crucial in the course of obstruction, sometimes the tumor and so. Nowadays, 2024, we also go to cross-sectional imaging. All right? So it helps us identify high-grade. What is high-grade? High-grade obstruction is obstruction of bowel where nothing goes through the obstruction. Even air is not going through, fluid is not going through, certainly soil is not going through. So we call that obstruction where nothing goes through a high-grade obstruction. And if it's a high-grade obstruction, usually the chances that it will resolve are less. Okay, sometimes people have said it does resolve, but it's very rare. So CT scan helps us to map our way forward. For example, it also tells us if there's ischemic bowel, because when you give contrast, the bowel will not take contrast. So CT scan becomes a crucial investigation tool. But before we do that, investigation tool for bowel obstruction, before we do the CT scan, we must make sure that we've done the renal function and the renal function is okay. Because if it's not okay, what do? We give them fluids, improve the renal function with fluids, and only then do we then do a contrasted CT scan. Okay, now we've done that. Okay, we've done its obstruction and this patient now has got a bowel obstruction. Okay, we've done, and it's complicated bowel obstruction. So what is the next step? The next step is we need now to decide, for example, if it's simple obstruction, what does mean simple? It means there's no ischemia. If it's adhesive, what do? We can treat the patient conservatively. So we use what is called the Bologna guidelines. Now, the city of Bologna, surgeons came together basically to map the way forward. And the agreement was that patients with simple bowel obstruction from adhesions can be treated conservatively and they resolve. What does conservative treatment mean? Conservative treatment means drip and suction. What does drip and suction mean? Drip and suction doesn't mean we give them fluids, suction in the nose, suction in the nose. No, we put a nasogastric tube through the nostrils, in the esophagus, in the stomach, and let it passively drain. It's actually a misnomer because we're not suctioning this, drip and suction, we're not suctioning it in truth. Right? In reality, we're not. We really is to put a nasogastric tube in the stomach and let it by gravity to drain, to empty the stomach. And we do these patients, for 42 to 72 hours. And if it's not resolving after 72 hours, we go and operate the patient. But these are the old guidelines. Now, the newer guidelines is you can actually go beyond that, beyond 72 hours, as long as the patient doesn't show signs of peritonitis or ischemia. So, remember, this is for adhesions. But if the cause was not adhesion, was incarcerated hernia, do we do drip and suction? No, we don't. So drip and suction is done for what? Only in patients with intestinal obstruction from adhesions. All right? So the others, no drip and suction. No. If the patient has got complicated bowel obstruction, can somebody tell me what does it mean to say someone has got complicated bowel obstruction? What does complicated bowel obstruction mean? Right? Anybody wants to answer that question? What does it mean? Complicated bowel obstruction. Anybody? No. Okay, I'm going to tell you what is complicated. All right. Okay. Let's see this. There's quite a few people. Vukewa, help us there. Vukewa, help us. Vukewa. What is complicated bowel obstruction?
Evening, Prof. So complicated bowel obstruction would be the one that's associated with features of ischemia, as well as clinical features of peritonism. So maybe there'd be evidence from from a blood gas that you did that shows metabolic acidosis or other forms of metabolic derangements.
Yes, correct. So that's the one with ischemia. That's complicated bowel obstruction. So if it's complicated, is there a place for drip and suction? Remember we said drip and suction, put a VIV line, nasogastric drip and then 48, 72 hours. No, there's no place. Remember, if it's complicated, it means it's ischemia. So if you leave it, what's going to happen? It's going to perforate. If it perforates, it's going to kill the patient? Yes, it will kill the patient. Do you want to wait for that? No, you don't want to wait for that. So if there's complicated bowel obstruction, the patient must go to theater as soon as possible. So the first thing that we do, but can we take the patient to theater? Remember what he said with appendix? So just like that, what must we do first before we decide? It's going to go to theater, but what do we do before we take him to theater? What do we do? Anyone? What do we do? Okay, Mpe, help us there, Mpe. Go ahead, Mpe.
So, Prof, before we can take the patient to theater, we need to optimize the patient. So, optimizing the patient would mean that we give patient fluid through 2 large bore IV lines. We put a urinary catheter and look at the urine output, aiming at 0.5 mils per kg per hour to 1 mils per kg per hour, checking the pH of the patient to be between 7.35 to 7.45, checking the base axis, checking the lactate of the patient, doing a UNE. So in essence, we need to make sure that the patient is safe to go to theater before we can just take the patient straight to theater.
Yes, correct. I think you said it very well. Okay, good. So to resuscitate the patient, optimize the patient. I think she spoke very well. And what we do to optimize it. Okay, now we optimize the patient. The patient is the end goals. You mentioned the end goal. BP must be this much. Patient must be wide, awake and alert. BP must be more than 100 systolic. The pulse must be less than 90. The urine output must be 0.5 ml per kg per hour or 1 ml per kg per hour. Yes, that is correct. That is correct, yeah. Okay, now you've taken them to theater, you find, you open, there is dead bowel. The bowel is dead. What do you do now? It's black, there's no contraction, there's no capacity to bleed, consistency is dead. What do you do now? So if the bowel is dead, we resect it. There is no Lazaro phenomenon. Now, Lazaro, those of you who are Christians who have read the Bible, Lazarus was risen from the dead, in the Bible, Olden Testament, in the olden days. So Lazarus was dead, was risen from the dead. So you cannot hope that your bowel can be resurrected from death. If it's dead, there's no Lazarus phenomenon. So what is dead must come out. So we resect, if it's small bowel, and then we join it. Even though if it's colon, because the bacterial load is so high in the colon, we prefer not to join. But small bowel, there's bacteria, but we can still join safely. So we resect and join. Okay, I think I'm going to stop there because now it's almost past the time. Before we close the session, are there any questions before we close the session? Any questions? Right. Okay, I think yeah, you've done very well, and you're responding very well because you are able to discuss and ask, and comment. Chile, you have your hand up.
So, Prof, I remember Prof said he's not available tomorrow. So we'll meet again on Thursday, Prof, at 7 p.m.
Yeah, we'll do Thursday because tomorrow actually I'm having a very early flight tomorrow to Mthatha, so I won't be, and I'm coming in the evening, the evening flight, so I'm going to land in Joburg, where time probably around past 7. So I won't be able to do the lecture tomorrow. Yeah. Yes, somebody asked the Shabangu. Go ahead. Somebody asked what the hell that.
Good evening, Prof.
Yeah.
When you were talking about drip and suction with simple obstruction, you mentioned that we can drain for up to 72 hours, according to the old guidelines, but then now I didn't hear quite well about when we can go beyond 72 hours.
Yeah, no, you see the Bologna guidelines, because sometimes these patients can be very difficult. So from time to time, experts meet, they review the literature and see what is available in the literature. So the first Bologna guidelines suggested 48, 72 hours. So if we go beyond 72, operate. But subsequent to that, there has been evidence that shows that you can't go beyond 72 hours. And the issue is the abdomen must be soft. There must be no signs of complicated bowel obstruction, which is, for example, the patient has got fecal odd material, he's got hypotension, he's got peritonitis on examination, all of those. But if they are absent, the abdomen is soft, we can go even 5 days. Sometimes patients have to be given TPN, to resolve. But again, it's an individual decision. Some surgeons believe we don't want to wait that long. Certainly, I wouldn't wait that long. I think the patient is around 48, 72 hours, we consider offering laparoscopic surgery. All right. Any other question before we close the session? Okay. Good, and good night.